Yes, I think so.
I think we can start. We should keep start in time.
Okay. Yeah, we should. Okay, so so I think apart from Amita and Mihir, I think everybody should mute.
Okay, so a very good evening to all the esteemed audience present today. Thank you for giving your time in today's busy days of webinars. And we are back again with the Tuesday Trivia, the monthly respiratory CME, in which we try to present to you some case-based discussions which would be helpful or relevant to your office practice. And today we are fortunate to have Dr. Gauri Shankar from Chennai, who is also an expert speaker today. And I would like to introduce the speakers one by one, the experts also. Dr. Gautam Ghosh, he needs no introduction as such, but still he is a senior consultant and DNB faculty at B.R. Singh Hospital, Kolkata. He's the national chairperson of the IIP Respiratory Chapter. He was there from 2008 to 10, and he's the principal advisor, National IIP-RC from 2021-22. He is a teacher par excellence, and he has taught so many of us students, and he's very humble. Every time he would say that, I don't know anything. You all know much better than me, but and he's a very humble and a very nice person at heart. So welcome, Dr. Ghosh, to today's webinar. And next eminent speaker who we are very fortunate to have today is Dr. N.C. Gauri Shankar, who is a pediatric pulmonologist and HOD clinical operations and quality at Mehta multi-speciality hospitals in Chennai. He is also a speaker par excellence, and we hope to hear much from him today. Next eminent speaker and moderator today is our very dear Dr. Devjani Gupta. She is a senior consultant at Narayana Multispeciality Hospital, Howrah, and Zenith Super Specialist Hospital. She is the EB member of the respiratory chapter of the WAP. She's the IIP ALS instructor for the last 15 years, more than 15 years. She's the president-elect of NNF West Bengal. She's also the chairperson of the cultural committee of the WAP, and to add that she's a writer and a painter. And I think we know her more for these activities also. Dr. Mihir Sarkar, he's a very good speaker. He's the professor and PICU in charge of Medical College and Hospitals, Kolkata. He's the teacher of College of Pediatric Critical Care. He's the East Zonal Coordinator and BOD member of the Pedistars India. He's the chairperson of Intensive Care chapter of Kolkata. And he has 45 original articles which have been published, and we have heard a lot from him, and hope to hear him speaking on the cases of viral pneumonia today. Last but not the least, we are fortunate to have Dr. Shumon Poddar, who is a DCH MD and assistant professor in charge of molecular biology in Institute of Child Health, Kolkata. So without much ado now, with such an eminent panel of speakers and moderator, we would like to start our topic today, which is on viral pneumonias. I think we would cover in the next 1 hour the A to Z of all that is required for your office practice in viral pneumonias. Viral pneumonias have been a menace in the last year during the month of September, October, when we had a lot of admissions of viral pneumonias, and in day-to-day practice also many a times we find such cases throughout the year in Kolkata because of the varied weather conditions. So I think today's CME would be a learning experience. So Mihir, I think I would request you to share your slides.
Okay. Thank you, Dr. Amita, for nice introduction. I will. The slides are visible?
Yes, please.
Okay.
Yes, you are visible.
Yes, the slides are visible.
Okay, thank you, Dr. Subhashish Roy and Dr. Amita for giving me this opportunity to talk on this topic on viral pneumonia with varied presentation and severity. My point of discussion of today's topic will be the viral pneumonia in children. Is it a real burden in our setting, especially in India? What is the main pathophysiology and what is the trajectory of the pathophysiology of viral pneumonia? And can we differentiate viral versus bacterial pneumonia in day-to-day practice? And what is the non-COVID viral status of non-COVID viral pneumonia in COVID era? And we'll discuss some case scenarios, though the case scenarios will be basically mainly hospitalized children and patients who are ICU. And there are some controversies around it, especially on the adjunct therapy we give sometimes in patients with severe viral pneumonia. Okay, so if you look at the burden in this, it is not uncommon. The community acquired pneumonia in under 5, considerable proportion of children are affected with the viral pneumonia. With the recent availability of this multiplex virus panel, and the cost is now being decreased, but initially the cost was a bit exorbitant, so not able to perform. But at least for severe disease category of patient who are needing HD or ICU care now get this test, and we are identifying and isolating more or more viral etiologies. And we should remember that viral isolated nasopharyngeal swab not always equate to viral infection. We have to look at the host. If their patient is immunocompromised, low birth weight, in ICU graduate, assign some symptoms important to corroborate with the finding we get in the nasopharyngeal swab. Sometimes we get only the rhinovirus, but it is the patient is mild symptomatic, but it is unnecessary to test all the patients. And we have to same time we have to remember that if we have isolated a virus, then it does not equate to it is an isolated viral infection, because many often at times it is associated with mixed infection like viral and bacterial. If you look at the US and Canada data, there shows that the 50 to 60% of the pathogenic organism of under 5 pneumonia are viral of etiology. This is the data from PGI Chandigarh. They have shown that these bronchiolitis patients with the 173 patients, the various etiology, most commonly the RSV, then the rhinovirus, and also the mixed infection is not uncommon. There are several mixed infection of the viruses, RSV plus rhino, RSV plus influenza, and it's difficult to interpret what is causing the main pathology. I think I will discuss more on the this panel discussion session. Our experience at medical college in 2018-19, we got many patients with whenever we started this virus multiplex PCR from the respiratory panel, we got this adenovirus surge at that time, and the mortality you can see is very high, around 56%. But in the meantime, in the COVID era, in the meantime, between as Dr. Amita was saying, the July-September 2021, we got up many cases of ILI admitted in hospital, and more than around 50% requiring the PQA's due care. And RSV was the predominant organism, and the ARDS present. And the atypicality was that they present not like the bronchiolitis, but like pneumonia and ARDS. And if we compare the COVID data here, the COVID, you can see out of around 10% of the patient presented with pneumonia in our medical college, and 20% in ARDS, and mortality death in among patients with pneumonia was 12%. So mortality was less, but in RSV, the mortality was very less, only one patient died. If we look at the pathophysiology, it is very important that the virus can cause the two effects, the cytopathic effect directly injuring the epithelium, and there is cellular debris formation, the cellular infiltration and inflammation, or there may be the dysregulated inflammatory response after a certain period of time. So this trajectory of the course of the spectrum is very important. From the COVID knowledge, we know that it may have different phases like the viral phases, pulmonary phases, and the systemic phases. So whenever the patient is presenting, and what is the main in pathophysiology at that process, it is due to viremia or due to direct cytopathic effect, or it is due to the host inflammatory, hyperinflammatory phase that will change the manifestation, also the treatment, especially regarding the need of immunomodulators and immunosuppressants like steroids. So that we have to keep in mind what is the trajectory of the viral pneumonia. So if we look at the pathophysiology, it may be predominantly affecting the airway disease like bronchiolitis with high resistance of lung, patient presenting with a wheeze or the bronchospasm. And other spectrum may be the lung parenchyma is mainly involved with low compliance, low perfusion, ventilation perfusion, and patient present with the ARDS spectrum. Or there may be the mixed pathology, which is most severe and difficult to treat. The patient both have airway bronchospasm as well as the lung parenchymal disease. So this mixed lung disease is very difficult to treat and need ICU and ventilation care. So can we differentiate viral versus bacterial pneumonia, clinical difference? If we look at that, but there are very soft signs, we cannot definitely tell it's the viral or bacterial pneumonia, especially in sick patients who are very admitted in the hospital and ICU. So patient with bacterial pneumonia most probably will have the high-grade fever with features of toxicity, multi-system involvement. But in COVID, we have seen that the viral pneumonia and influenza can cause the multi-system involvement. Focal lung involvement, especially the consolidation, is more common in the bacterial. Diffuse involvement is more common in the viral. And pleuropulmonary disease is more common in bacterial. And as I have said, that the broncho and the parenchymal disease is more common in the viral etiology. But this all is not a definite sign, but it can be overlap. So lab investigation, can they help? Usually the total leukocyte count will be high in bacterial pneumonia, but it's more or less normal. Neutral NLR ratio we have used in COVID in a very in patients to high NLR ratio found in the hyperinflammatory state. So initially in bacterial pneumonia, the NLR ratio will be higher. But if the viral pneumonia trajectory is in the hyperinflammatory phase, then also the NLR ratio will be high. Also, the severe cases and the hyperinflammatory stages, the CRP and procalcitonin may be even high in viral pneumonia. So how the patient is presenting the disease symptomatology and the disease trajectory is very important to interpret this investigation results. So this is the study, one of the study, can we predict the community acquired pneumonia by physicians versus data-driven? It is a viral or bacterial. The result of this study shows that the discriminating abilities of the artificial intelligence approach is low to moderate in case of viral or bacterial pneumonia. And the discriminating ability of physician or the experts are very low to very low in viral and bacterial pneumonia. So in severe disease requiring the ICU or the hospitalization, the discriminating ability of these two categories are very low. So it is very important to identify the coexisting and pre-existing disease, because the viral pneumonia doesn't always play the severity alone. Sometimes it's associated with myocarditis. And the patient with cardiac disease like VSD can present with viral pneumonia. CNS patient sometimes present with the encephalopathy, or the patient with neurometabolic disorder or the cerebral palsy child can present with the viral pneumonia. So the coexisting and a pre-existing disease also play a significant role in the disease spectrum and the pathophysiology. Non-COVID pneumonia in the COVID era, so it is sometimes difficult to identify, because initially the unless the COVID report is not available, labs are not doing this other virus multiplex PCR. So it was difficult to identify in the initial phase of the pandemic. But it is, though the COVID, particularly the isolated COVID pneumonia is not so common in children, fortunately, in comparison to adult, but we have found in our setting but the non-COVID pneumonia can exist in the COVID RT-PCR stage. The studies have shown that the influenza infection increases the mortality associated with COVID infection. And how COVID infection, co-infection of COVID and the non-COVID behaves, and does they increase the severity? Yes, the studies have shown the influenza infection associated with the COVID increases the severity. And how COVID seropositivity affect the non-COVID viral pneumonia, this answer is still don't know. The many of the children are the COVID antibody positive, but does these children have the severe other viral non-COVID viral pneumonia? That the hypothesis was put forward during this RSV surge in the month of August, September, but there has been no proof of that. So this is one of the study. This the adult studies, the influenza co-infection associated with severity and mortality of COVID-19 patient. This had been shown that the viral co-infection increased the ICU admission and higher mortality in COVID-19 patient if the patient have H1N1 infection versus the bacterial co-infection. So other viral co-infection increase the COVID infection mortality. Now going to the case series. So this is one of our patient presented with severe respiratory distress with sub 4-month-old 6 kg, having severe respiratory distress, cough, coryza for 5 days and breathlessness for 1 day. And airway was maintained, but the respiratory rate, patient is tachypneic, desaturating with oxygen, and the subcostal intercostal retraction was there. Chest bilateral bronchi was present, and the heart rate hemodynamically patient was stable. This was the X-ray, if you can find. So this is, there are hilar infiltrates both sides in the right and left, and the but the peripherally there are some clearing with the associated with hyperinflation. So both the parenchymal and the hyperinflation disease infiltration and hyperinflation are there. And the patient was initially, the residents treated in the emergency patient started with coamoxiclav injection and the injection of oseltamivir. They started with the face mask oxygen and started nebulization with the epinephrine. One is 1000 and the 3% normal saline 3 times in the first 1 hour, but patient didn't improve. Patient put on high flow nasal cannula 6 liter with FiO to 40%. By respiratory multiplex viral PCR and the COVID RT-PCR was sent. In next 4 hours, patient becomes very much irritable. So patient needs some sedation in the form of dexmedetomidine infusion, 0.4 microgram per kg per hour. But bronchospasm was worsening and the patient has severe bronchi. And so the patient was given a trial of magnesium sulfate of 50 mg per kg over 20 minutes and repeated after 12 hours as well. And the resident started the hydrocortisone 5 mg per kg and then the 5 mg per kg 6 hourly for a short period for 3 days. Though these adjunct therapies are still controversial in case of viral pneumonia, whether should we use or they increases the disease mortality. So the question remains, should we use the sedatives in patient with respiratory distress? Is there any evidence of MAXALP in bronchiolitis or viral pneumonia with predominantly presenting like a bronchospasm or wheeze? And after COVID, where do we stand regarding the use of steroid in viral pneumonia? So the case progressed like that. The patient didn't respond to HFNC. The flow has been to increase to 12 liter per minute and FiO to 60%. Even after that, the patient, there is no significant improvement. So you have to put the patient on non-invasive ventilation pressure support. And after increasing the support of PWP up to 6 and the PCAP of 10, the patient settled down and the respiratory distress assessment instrument score becomes moderate from severe, and the ABG was range becomes in normal range, and the patient gradually weaned up in the next 72 hours. But the story doesn't end here. On the day 240, after 48 hours, patient has severe tachycardia. Blood pressure, though, was maintained. Patient was normovolumic, but ECG shows sinus tachycardia, non-specific ST elevation. Patient had low-grade fever, and echocardiography shows the hyperdynamic pericardium, heart myocardium, and ejection fraction 78%. The cardiac biomarkers are markedly raised. And the patient, so the features of myocarditis. And in the meantime, the RT-PCR report was available. RSV was positive and COVID RT-PCR was negative. And the child was given the view of myocarditis, the IV immunoglobulin was started, and the next 36 hours, the child was improved and ejection fraction becomes 64%, heart rate decreased, and the patient was discharged from peak 1, day 6 of infection. So there are a lot of controversial issues like the use of adjunct therapy in case of viral pneumonia, and if there is coexistent of the disease like myocarditis is present with this viral pneumonia. Now, another case scenario 2, this patient with B cell ALL, 7-year male, patient had neutropenic colitis as was improving, treated with meropenem, ticoplanin, and caspofungin in our hematology unit. Patient was improving, but on the day 7 to 8, the child had developed cough and respiratory distress, desaturating tachypnea and retraction, and the oxygen therapy with NRBM mass percent, COVID RT-PCR, and the viral other respiratory viral RT-PCR was sent, and the COVID becomes subsequently positive. And this is the chest X-ray. You can see the ground glassing and the interstitial infiltrate of the both the 4 quadrants are involved, and there is ground glassing in the X-ray. So what is the course and management? The patient ultimately needed the high flow oxygen, but didn't improve, ultimately required the non-invasive pressure support ventilation, IPAP of 16 and EPAP of 7 and FiO2 of 60%, and patient was settled on that. And if you look at these parameters, there was high inflammatory markers like CRP-ESR was high, D-dimer was raised, and the patient other respiratory vital panels didn't show any growth. So in this setting with COVID positive, with patient with immunocompromised leukemia patient on chemotherapy, we started the patient on steroid with methylprednisolone, low molecular weight heparin started, a D-dimer was high, and the remdesivir was started because the immunocompromised patient with neutropenic, and with the 2.5 mg per kg on day 1, then 2.5 mg kg from day 2 to day 5. But on day 4, again, this patient had tachycardia, low blood pressure, hypotension, but patient ejection fraction becomes only 26%, and the patient had the high pro-BNP was high. And you can see that the echocardiography, the cardiac contractility is poor. And on this setting, the myocarditis, the patient was fulfilling the MISC criteria. Patient required the infusion of with the triple ionotropes like noradrenaline, dobutamine, and milrinone. And we started the patient on methylprednisolone, and in methylprednisolone's dose was increased from 2 to 10 mg per kg, and IVIG was given. And patient next 72 hours, child was improved, ionotropes tapered, and respiratory support was weaned up, and patient again transferred back to, this was the final X-ray after getting the treatment, after receiving the whole course of treatment, and patient was transferred back to the hematology department. Last case, the case scenario 3, this is the 3-month-old child. This child has very stormy course. The this is a preterm 28 weeks, very low birth weight, and the and the history of birth asphyxia, now 1.9 kg, incompletely immunized, has 30 days of essential stay due to prematurity, followed by 21 days of essential stay due to meningitis, and initial investigation shows the torch profile was negative. In this patient, now presented with a cough with cold for 3 days, respiratory distress for 2 days, and there is marked tachypnea, and the saturation was only 80%. The severe intercostal subcostal retraction, altered sensorium. The patient was in respiratory failure, and patient was intubated and ventilated. So you can see the chest X-ray. This is very bad, and there are infiltration in the both lung fields and all the 4 quadrants, and there is also there is dense opacities as well. But even after putting the patient on PRVC mode, the child was not improving. PIP requirement was high, but saturation was able to achieve only 85 to 80%, and there was persistent hypercapnia and hypoxia. On view of this, the patient was put on high-frequency oscillatory ventilator, and the map of 22, amplitude 30, and the frequency of 8.5, and patient was prone. And antibiotic was started with the meropenem and teicoplanin because the patient has already got the various antibiotics during the previous days, and the oseltamivir, oral oseltamivir was also started. Respiratory viral panel report came, which has showed that the adenovirus was positive. Initial blood culture shows no growth, but the ET tube aspirate on D3 shows the Klebsiella, which was carbapenem resistant. And this was another super infection along with the adenoviral infection. And the patient meropenem was stopped, and the colistin was started for this patient. And if you look at this, the patient on high frequency ventilation in SLE 6000, initially the patient has required MAP requirement was very high, and but gradually the patient improved and the MAP requirement becomes 17, and the oxygenation and the video is not playing. I'm sorry for that. The video is not playing, but gradually we could wean off the patient with the requirement of the MAP and the delta P, and the patient, the oxygenation and the ventilation was improved. Okay, so gradually the patient on high frequency, this is the chest X-ray after getting the high frequency oscillatory ventilator for 72 hours. It improved, but there are still infiltrates present. The patient was shifted back to conventional ventilation 3 days. Post-extubation NIV requires 6 days and then HFNC for 5 days. So we need the very gradual and slow weaning of this patient and discharge after 1 month with the budesonide metadose inhaler of 100 microgram per kg to microgram 2 times and azithromycin with anti-inflammatory dose. And after that, the patient was discharged. So in conclusion, I can say that the viral pneumonia can have varied presentation and severity. Dynamic need of respiratory support according to the disease pathology is important. Whereas the patient needs continuous monitoring if the patient is severe disease and need to escalate their therapy according to the presentation. Think of co-infection, super-infection, and coexisting illness if you're suspecting a viral pneumonia. So that is a coexisting myocarditis or the super-infection with the other bacterial or fungal infection can complicate the disease course. And controversies remains on use of adjunct therapies like bronchodilators, steroids, magnesium sulfates in case of viral pneumonia. But we need to tailor the therapy as per severity, individual disease trajectory, and the pathophysiology, how the patient is presenting to us. Thank you. If any question, we can discuss on the panel discussion session.
Devjanidhi, please continue.
Okay, just let me go on to the slide share. Is this visible?
Yes, madam.
The slides are visible. Okay, let's see if I'll just roll the slides, and if you just tell me the slides are moving. Okay.
Yeah.
We are good to
Next
go.
slide mode. Next slide.
In the slide mode, sometimes, you know, the slides don't seem to move. Okay, I will just try. Okay. Are the slides rolling? Yeah?
No.
Oh, no.
Okay, no, then I'll switch off the slide mode. Yeah. Okay, so just 1 minute, please. The slides are rolling?
Yes,
Yeah.
this is good enough.
Okay, so I think we will. Thank you, Mihir. That was a wonderful start, an overview with a lot of in-depth discussion on very sick children in the PICU. Now, well, most of my work is in the community, in the OPD sector, and given the experts who are present today, so you know, I cannot kind of resist the temptation in putting forth a whole lot of questions that bothers the pediatrician who's seeing the child in the OPD with symptoms related to viral pneumonia. So here goes. Now, pneumonia, as we all know, it is an extremely old disease. But the fact remains that in spite of extensive research, it continues to be the single largest infectious cause of death in children. And the 2021 WHO statistics says that it accounts for about 14% of all under 5 deaths. And somehow, in spite of the research, in spite of the high-tech treatment that we seem to have progressed in, there has been, you know, the progress in reducing pneumonia death has been significantly slower. And all of us know that the mortality and the morbidity is linked to, you know, a lot of causes: nutrition, sanitation, pollution, and things like that. So, pneumonia, an inflammatory disease, Mihir has described the basket of virus that seems to attack the children. I would request the experts to kind of slant their answers towards non-COVID viral pneumonia. So maybe talk on RSV, adeno, parainfluenza, and the rhinovirus. But what we need to, I'm sure all of us understand that viral and, we know the pathogenetic mechanisms, and hence we know that viral and bacterial pneumonias, they're not mutually exclusive. So an invasion of the lower respiratory tract by a virus could be followed by a superadded bacterial infection. And you do not know when you're seeing, at which stage of evolution you are seeing the child in. And hence it is very important for a continuous clinical reassessment, be it OPD-based, be it hospital-based. So the first question goes to Dr. Gauri Shankar. Fever, cough, fast breathing, the traditional textbook teaching of symptoms of pneumonia. Well, we do know that there is no definite differentiating clinical markers between viral, bacterial, and atypical pneumonia. What would your advice be to the pediatrician sat in the OPD? Are there any clinical or epidemiological cues that the pediatrician might use that would kind of help him to suspect a viral etiology in the OPD setting? Dr. Gauri Shankar, please.
Thank you very much, madam. Thank the opportunity given. Probably like when I am sitting in the OP, whoever comes with the child, most of the time it's going to be the mother, very rarely the father. And by the voice of the caretaker, I know whether they have any respiratory symptoms or not. If they have a respiratory symptom like a hoarse voice, sometimes sneezing, occasional cough, it just gives me a pointer even before I can think deep into it. Oh, the family member, one of the family members has got something like a respiratory problem. So I'll ask if anyone else has got a problem, either in the descending order or ascending order or sequentially or all at the same time. This may give me a clue. Most likely I'm dealing with a viral pneumonia. This is number one. Number two, like probably we don't have seasons like what US and UK say, fall, then winter. If we are going to have a croup acute laryngotracheobronchitis, we know most often it is going to be due to parainfluenza. If we are going to see 2 or 3 cases over a period of 2 or 3 months, then we know this is the next season is going to be RSV. So this, some epidemiological factors also plays a part, but this also helps me. If I see a crew, I always make it a point, okay, in another 2 or 3 months, we are going to get an RSV. Because most of the time, your crew is going to be an acute onset, it's going to be a viral infection. Third, looking at the eyes of the child, a conjunctivitis, a child with conjunctivitis with a respiratory problem, I know I'm going to more towards an adenoviral infection. And number 4, if it is going to be a viral than bacterial, it will involve many systems, not one. Child can have vomiting, child can have loose stools, child along with it, child can have fever. The fever very rarely is very high, like unlike a bacterial pneumonia. Bacterial pneumonia, many a times, first day a mild fever, second day, third day, the fever keeps on increasing. Whereas in viral, the prodrome is not like that, and the intensity of fever is not as high as a bacterial pneumonia. This is what I can say for your question, madam.
Thank you so very much. Good cues for us to pick up on. My next question goes to Dr. Gautam Ghosh. Well, the teaching is that the cough is a protective reflex. It's a symptom, but it is distressing for the child. The child who has sleep disturbance because of the cough. The child might be vomiting. It's nightmare for the parents who are up with the child who's coughing away, and it is anxiety, and you have the anxiety-ridden practitioner. Not to say, just because of the cough, you might have a whole lot of doctor shopping going, because they would think, well, the child's been coughing, and the child doesn't seem to improve, and for some reason, the cough is a very much an integral part of viral pneumonia. So the malady, to treat or not to treat. If yes to treat, then why? If not to treat, what justifies not giving some bit of aram to the parent and the child? And if yes to treat, what do you treat? Because you have an overloaded basket roaming about in the community, and in the, you have combinations, isolations. So what do you pick and choose? So over to you, Dr. Gautam Ghosh.
Good evening. Cough. We don't want to treat cough. We want to treat the cause. We accept it's a protective reflex. So if we try to find the cause of the cough. If it is a spasmodic cough, we need bronchodilators. If it is a dry cough and really disturbing the child's normal lifestyle, only occasionally we need dextromethorphan or levocoque, the cough depressants, very rarely. We don't want to treat allergic cough. Neither we want to treat with Montelukast, anything. These are the disease modifying organisms. We need to treat with asthma for some other issues. Role of cool mist humidifiers are controversial. Usually that the only thing that if you want to depress the cough and the origin of the cough is in your upper airway, you can use a cold lozenge. Absolutely, and that prevents the sensory put-up. So in short answer, treat the cause, not the cough. Give expectorants or I would not say expectorant, bronchodilators if there is a spasmodic. Mucolysis has no role. Cough suppressants very, very, very rarely. Don't treat Montelukast combinations or allergic until unless indicated. It has no role to do the cough. Role of cold mist humidifiers are controversial. You can take an strepsils or Alex type of law, inhibiting the sensory stimulus. And finally, to end this story, coughs are never predictive. Whether even the type of cough will never predict it is viral or bacterial. Thank you.
Thank you. Dr. Ghosh, could you just amplify a little bit more when you say that the role is controversial with respect to cool mist humidifiers? Like, do you say controversial because it's practiced more in the Western Hemisphere rather than in this bit of the country? Like, where lies the controversy?
How do you expect a cool mist humidifier act? Cough is a reflex. It has a sensitive sensory route, afferent route, center, and efferent route. It can be local center. It can be in the CNS. Cool mist humidifiers will go on the nose, upper airway. We don't expect that goes into the alveoli.
Okay, yeah, thank you. So,
why are you producing so much amount of cold mist? Even some people say hot steam bath, useless.
Yeah, yeah. So the key message is treat the cause and not the symptom, right? Yeah. Okay. So the next question goes once again to Dr. Gauri Shankar. The child is at home. You think that the child can stay with the caregiver at home. For differentiation between a viral and bacterial pneumonia is difficult. Would you comment on this line that in such a setting, in the domiciliary treatment, use of empirical antibiotics is prudent and rational? If yes, why? Then what sort of antibiotic? And if no, why?
The answer is going to be a big no, because the available literature, we go by evidence-based medicine. And the available literature now says majority of pneumonia, not even 50%, majority of pneumonia, not only in developed countries, but also in developing countries, it is due to virus. For us, we are used to writing antibiotics. Habits die hard. But when we have evidence to say that children whose respiratory symptoms, whether in a developed country or in a developing country, they do a rigorous study and tell us that virus is the most common, then we should refrain from using antibiotics, especially in OP practice. Because in office practice, we have the luxury of seeing the child even 2 times in a day, both morning and evening. Then the next day, morning and evening, we are able to follow up the child. So if the parents are anxious, if they are sitting on our head to prescribe antibiotics, tell them, please, you come back in the evening. I'm not going to charge you. I'll just see how the child is doing. For me, it looks like viral. So a lot of counseling has to go in this situation, rather than writing a medication and probably not following an antibiotic stewardship, because we are the culprits. Because when we don't have the time just to send the patient off, and if the patient is going to ask the second time or third time, okay, Baba, I'll write antibiotic. No, we should take time, because like it is very easy for us to write the antibiotic, but how will you prevent the resistance coming up in the society? Like we cannot do that. As a responsible pediatrician, it is our duty to convince, to like counsel, and if they are not really accepting what we say, it is up to them, but please don't use that. And having an antibiotic which was prescribed for an infection about 6 months back, the patients, they use the same prescription to buy that and give that before they come to us. So government also has to step in and say the prescription what we give on a particular day should be honored only for a certain period of time, probably between 2 to 3 days, not beyond that. This has to be there so that we can practice rationally. Thank you.
Very important messages laid down. An answer, big no. Parent education, parent counseling, revisiting. Wonderful. The next question goes to Dr. Gautam Ghosh. The child is still at home. You think the child has viral pneumonia. Now, the child's not that unwell to step into the hospital. You do not have tests yet or results yet done for an etiological diagnosis. Comments on starting oral antivirals in such a setting on a domiciliary footing?
It's a very difficult decision for a pediatrician. When I say the question is important, it means the answer is difficult, but I'll take 3 steps. Number 1, which day of illness the child is suffering from. Number 2, clinically, does the child live septic or suffering from bacterial infection, which is very difficult. The issue is he will be fine in between fever, fine in between bouts of cough. He is probably viral. But if he is dull, even when the fever is not there, there can be so many other issues. And number 3, how is the progress? That's very important for an OPD pediatrician. He comes on day 1, he never follows up. And if you ask him to come daily or alternate days, they're very much worried if it's a paying clinic. And I finally finished doing a biofire. I think Shumon will give an answer. Or we're doing a nasal swab, which costs to in Calcutta almost close to 8 to 10,000 bucks.
Yeah, we'll come to that. We'll come to that. Yeah, we'll come to that.
Yes, normal process. It will be more irrational to advise all children to send 10,000 bucks, right? Rather than it will be less irrational if you give an antibiotic on clinical point of view. All
antiviral, yeah.
Yes, if it is after 3 days, he is sinking, he is not following up, better to err on the worse side.
Okay, thank you. I come back to Dr. Gauri Shankar once again. Well, you know, this pediatrician in the community, has been following this child up, and he or she thought it prudent that the child, he would do at least one investigations, and he goes ahead and asks for a chest X-ray. So you have a child with suspected viral pneumonia. You are happy for domiciliary treatment. The questions to you are: do you think at this stage a chest X-ray is mandatory? Like, what information are you trying to gather from a chest X-ray? Number 2, chest X-ray is open to interpretation in different ways by different radiologists. And does any particular finding on the chest X-ray point towards a viral etiology? So questions over to you, Dr. Gauri Shankar.
Thank you, ma'am. X-ray, many a times, when we are in doubt, we take, but some of the intelligent patients, they themselves go get the X-ray and come. It is not us. It happens everywhere, whether it is north or east or west or south, this happens. So we need to look at the X-ray. This helps us, number 1, a bilateral hyperinflation. That means if you are able to see up till the anterior end of the 7th rib or 8th rib, then you know it is a hyperinflation. Second one, a flattened diaphragm. Then you know this child has got a wheeze, which you are able to interpret in the X-ray as a bilateral hyperinflation with flattening of diaphragm, more air getting trapped in the lung. So most often viral infections trigger a wheeze, and there is bronchospasm also, along with cellular debris obstructing the bronchial, obstructing the airways, leading to air trapping. So this is one clue that we are dealing with a viral. Second one, we may be able to see more or increased bronchovascular markings. What does it indicate? It indicates the bronchial walls are getting thickened. This happens, edematous. This happens in most often in a viral infection, because a viral infection, it does not remain in the alveoli. It's like lower respiratory infection most often is viral. Like all the airway gets inflamed. It is not something like a bacterial pneumonia where it is localized. So the airway wall, the bronchial wall becomes edematous, becomes inflamed. So you are able to see increased bronchovascular markings. As Dr. Mihir had put in the first X-ray, in the first case, around the heart, you see parahilar peribronchial infiltrate. The periphery appears very clean, but all around the heart, you have as if a lot of haziness. So this again points out to a viral etiology. even though by looking at the X-ray, very difficult to say that it is viral or bacterial as per the etiology, but these are points to help us to differentiate between these two.
Okay, thank you. Okay, so I'll go over to Mihir now. So, Mihir is the PICU in charge in a tertiary care hospital, looking after a lot of sick children. Well, this child kind of decides to upgrade himself from an outpatient management to an inpatient one. Guidelines for red flag signs. When would you think of shifting stance in your treatment, Mihir? And number two, you have the child arriving in the emergency room. What are the instructions? You know, it's a very busy tertiary care hospital. So what are your instructions to the paramedicals and the medical staff with regards the judicious triage of such a sick child in the emergency room? You know, how long in the ER, shift to ward, shift to HDU, shift to direct PICU from ER. So what are the guiding instructions? Over to you, Mihir, in a nutshell, as quick as possible, please.
Thank you for the question. So regarding the red flag sign for hospitalization is very important, because we have to counsel the parents who are in the domiciliary care when to come back and when to need the hospitalization. Especially if the fever is persisting more than 4 or 5 days, then the patient have signs of respiratory distress like fast breathing, then you have to educate them to how to count. And if the patient has the saturation measurement is not possible most of our setting in the home care, so that is not always advisable. But if the child is feeding is significantly decreased and less than, suppose say less than 50%, if the urine output is less than 4 to 5 times per 24 hours, patient a persistent fever with fast breathing, then these are the features when the child need hospitalization, and you have to educate the parents to pick up early and when to come back. Again, if the patient arriving in the ER, it is very important to triage who are very in a sick and severe life-threatening situation and who are in the priority signs. If the patients have signs of respiratory failure, like the patient have distress with altered sensorium or other system involvement like the shock, then that patient require direct PICU admission. If the patient have respiratory distress in the form of fast breathing or mild subcostal intercostal retraction, but the saturation is maintained, or the with the nasal mask or the nasal prong, and the patient settle down within the half an hour to 2 hours, then that patient can be managed to the ER. And if the patient require like high flow, if the patient distress, the retraction is not improving, the patient require the high flow oxygen therapy, or and further deteriorating, or the disease is severely progressing, then that patient required to transfer to the HDU for more monitoring. And and we have to monitor the patient if for deterioration as well as the improvement. If there is deterioration, we need to escalate the therapy.
Thank you, Mihir. Just to ask, given the present logistics in the city that we practice in, is there any scope of a 4-hour stay or a 6-hour stay in the emergency bay and then home from there? Home from emergency bay, after a 4-hour period of observation or a 6-hour period of observation, and then the child goes home?
That is the most commonly recommended for moderate bronchiolitis or patient with moderate distress with pneumonia, and we do for asthma patient, because if they come to the hospital. But in a small child who is coming with a viral pneumonia, which is requiring patient, we don't requiring the emergency visit, and within the discharge within the 4 to 6 hours, if the patient staying far from the hospital, then it has always been difficult, and the patient may come up in a very serious stage at that time. So for a smaller infant, it is also difficult for parents to judge them and to get the decision. So for infants, always we advise to admission to stay at least 24 hours and then after that discharge.
Couldn't agree more. Absolutely. You had a couple of slides about a very sick child, and there was a wonderful question about the use of sedatives in a child with respiratory distress. Could you just take probably 1 minute to amplify on that. You have a hungry, fretful, irritable child with respiratory distress, and you have a super anxious parent. Modalities of monitoring and supportive treatment. No, I'm not talking of the etiological treatment. I'm talking of the supportive paraphernalias.
Yes, so there are a lot of factors that lead to this irritability, anxiety, and not taking the respiratory therapy properly, because the child is very anxious, in the atmosphere is different, and there are a lot of noise and a lot of new faces, and the child is all at the same time is hungry, need foods, and it may be the irritability due to the hypoxia. So we have to judge what is happening to the child and at that time. So always take the help of the mother or the parents, keep the child on the lap of the mother, try to counsel the mother to try to take the help of the mother to provide the oxygen therapy at the initially. Then if you can start, if the child is not in a severe respiratory distress, on you can start the feeding with the supervised feeding by the you have to stand by the side of the patient. If the child is not being more become fatigue, or chance of aspiration is less, then you can start supervised feeding. If that settles the irritability of the child, that is fine. Always, and also the same time, the nasal clearing, one thing is that a very minor procedure, but it helps many times, because the blocked nose leading to severe irritability, and if you clear that, then the most of the time the child can settle. Even after doing all these things, if the child is still irritable and require the escalation of the respiratory therapy, then we give the very low dose monitored sedation, like mildly sedative, and as well as which have analgesic properties like dexmedetomidine, by monitoring the child. Though ideally it should not be provided in a patient with respiratory size, but for the practical purpose, we have to sometimes give to provide the respiratory therapy adequately to the child.
Thank you, Mihir. I think that was very crisp and concise. Okay. Now, this question, I revert back to you. You presented a case series, right? And you had a backup of investigations done. So let us not yet go to the investigation part. So you have this child hospitalized. Any clinical signs that kind of gives a pointer towards, well, it could be RSV, it could be adeno, or it could be bad influenza? You do not yet have the results of the etiological diagnosis coming through.
No, it is very difficult. I think the answer is no. But if the season is that, if the epidemiological pointer are there are many cases of RSV you have already diagnosed, or adenoviral you have already diagnosed, or the other centers are getting this particular type of virus, then it is you can assess. But otherwise, it is very difficult, because they can have overlapping features and varied clinical presentation, and it is very difficult to diagnose clinically which virus is causing.
Yeah, and you could have mixed infections as well, isn't it?
Yes.
Okay. Has ribavirin gone out of fashion? Aerosolized ribavirin. Question again to you, Mihir.
Ribavirin, I think I have not used in any patient, and it is not available to our setup as well. So I don't have any experience.
Okay, can I ask the same question to Dr. Gauri Shankar as well? Ribavirin as an antiviral, aerosolized antiviral. So is it still in vogue? Is it easy to give? Easy to procure? Is it effective?
Till now, I have not seen use of aerosolized ribavirin. What we have is the syrup only, which is as good as a placebo. So I don't have the experience to comment on ribavirin, because I have not seen it being used in the centers where I go in Chennai. I have not heard it in India, even if many of the centers with whom I have interacted, I don't think it is being given as aerosolized form too.
Dr. Gautam Ghosh, any inputs?
No, I have no personal experience of using this drug.
Aerosolized ribavirin. Okay, so that's a no-no from our experts. We have Dr. Shumon over here, and I need to bring him into the discussion. So you have this child who's hospitalized. being treated for viral pneumonia, is there any role of monitoring acute phase reactants in this setting?
Yeah,
The acute phase reactants, are they sensitive? Are they specific? Do they help you to differentiate between viral and bacterial? Why do it? And how would you justify and rationalize?
Yeah, thank you. Thank you for this question, because every time we are very much relying on CRP. If the CRP is high, it's bacterial. If the CRP is low, it's viral. It's no such clean-cut distinction. Sometimes CRP, there is one such acute phase reactant, or maybe more towards it, maybe procalcitonin, although it's little costlier. No single acute phase reactant can be relied upon solely. It's basically what should I say? It's an orchestra. On one hand, that is the clinics. On another hand, that is the radiology, and on the third parameter that comes from the lab, that is in the form of what is the leukocyte count, what is the whether it is neutrophilic or lymphocytic, that is NL ratio, and then comes the procalcitonin if available, and CRP. All these together, if put in one picture, then you need to interpret on the bedside clinically. If the CRP is very high, that can be in case of adenovirus, and even a child with severe pneumonia, sepsis, if the child is newborn, the CRP may take time to rise because all the other systems are failing. So do not rely on particular parameter on a sole basis.
Dr. Shuman, would you say that it is rational to say that following the progress of acute phase reactants, the increase or the diminution, does it have any correlation to the progress of the disease? Does that justify?
Yes, to some extent it can, because if within 48 hours of therapy, whatever we have done, if the procalcitonin is rising super fast, then whatever we are doing is not helping the child, that's for sure. Maybe we are actually thinking it a case of viral pneumonia, but actually it's a coexistent of bacterial versus viral. On the other way around, if we are treating a case of pneumonia as a condition of maybe viral or bacterial with antibiotic, then the child is improving within 48 hours time, the procal is coming down. I'll more rely on procal rather than CRP, although it's little costlier. But again, both of them to be taken together simultaneously. If the child is improving clinically and the biochemical parameters are also improving, then we can think of, yes, our treatment is responding. So progress of the disease, yes, to some extent, we can rely upon this.
Okay, so the next question, it's a very busy slide, and I do not like busy slides. I never have such a busy slide. But having got you on this panel discussion, so I kind of jotted down all the questions which a pediatrician in the community could ask you. So viral studies, when to do, how early on in the illness, whom to do, and how do I rationalize doing, justify doing an expensive, viral studies? The handling, sampling, transportation, it kind of influences the results. So where do we go from there? And what are the newer tests in the horizon, not just in the city, in India, or probably overseas as well? So over to you, Dr. Shuman.
Okay, thank you for this pertinent question. I will take 3 minutes time. Please bear with me. I will be going one by one. First of all, diagnosing a case of pneumonia, whether it is viral or bacterial, first of all, we are treating the child, not the report. So we need to take care of the child clinically with some associated maybe some biochemical or some radiological features. We need not to do all these costlier tests like this viral panel and all this in the OPD basis. We need not to do that for every child. It's absolutely not required. If the child is in a bad shape and we are thinking that we are we dealing with a case of a very severe viral infection, or maybe some non-COVID, especially in this past few months, the RSV, and in the 2 to 3 years back, as Mihita also said, there was an outbreak of adenovirus. It was a nightmare in Kolkata. So in that situation, if the child is getting admitted and we are seeing that we are not very much convinced about what we are treating with, then we need to have something extra, and that something extra comes in the form of this respiratory multiplex PCR. We know only one name of BioFire because of their marketing ability, but there are certain other parameters or platforms as well. We are using similar such platform apart from BioFire. So there are companies coming up with a lot of such things. Now, how to send the sample? Once Smith has said that rhinovirus is coming. See, rhinovirus is a commensal in the nasopharynx in this area. So if I am getting rhinovirus, that means maybe my sample collection is not proper. What I always say, sometimes there might be 3 or 4 virus coming in the same multiplex PCR. Now, which one to take? It's absolutely useless if you have 4 or 5 diagnoses from this PCR. Then actually the sample taking is very, very important. And how to do that? Every bad thing has got some blessing as well. During this COVID era, we have learned how to take the samples. Now, first of all, we need to clean this nose and the nasopharyngeal area with some one swab, then discard that swab properly, then take the actual swab which I am going to test. Now, introduce it properly. Just we know how to take it that swab by this time. Now, keep it in the viral transport medium as early as possible. Immediately break the additional part of the stick, close it up, sealed it in a pack, in a Ziploc. We know from this COVID era nowadays, but always transport it in the cold chain. That is very, very important because we are testing the nucleic acids. Nucleic acids are very friable, very fragile. So until and unless we are keeping it in the cold chain, all the tests will be invoked. Now, when sending it to the lab, once the lab has received it, it's lab's duty to immediately store it to the refrigerator, or if available at -20, and if it's suspecting for longer storage than -8, whatever be the situation as per availability. Now, during the study, during the transport, sometimes samples are coming from the periphery. So during the transport, this cold chain has to be maintained. This is very, very important. Now, once the lab has now started processing the samples, now it's always prudent if you give lab the proper history, especially with the biochemical parameters, so that some of the time we face little problem to say certain organism whether it is present definitely or not, because it is sometimes in a borderline range. So it is that time, since it's a multiplex PCR, it is actually melting curve analysis. Melting curve means it's actually a nucleic acid which melts, which breaks at a particular temperature because of the ATGC bonding amount. So that is specific for that organism. Based on this principle, this multiplex PCR is working. So if we have certain clinical parameters as a form of history, then it becomes a little easier. Even on certain occasion, we have seen that probably all other organisms are coming negative and adenovirus is showing just positive result. Probably we have collected the sample when the child is already improving. So at that time, adenovirus just below the threshold, but that diagnosis will help the clinician. Okay, you have done justified. You have done what treating the child as a viral pneumonia. Wait for a day or two, the child will improve definitely. Just give some supporting therapy. And one more thing, Mihir just said, there may be sometimes coexisting infection or superadded infection. I'd like to highlight two things. Whenever we are trying to do all these BioFire or other multiplex PCR, there we are targeting mostly one set of organisms, and which are very difficult to grow, like atypical bacterial organisms and definitely the respiratory viral organisms. But very soon, tests are coming with a wide array of choices where you will be having plenty of bacterial, both typical and atypical, and the viral etiology as well. So it will be a spectrum. So we will be having total spectrum in the report. Next comes one more thing, keeping in mind the sampling. There is pneumonia over the chest, and we are taking the sample from the nasopharynx. So it may not corroborate always. Closer to the site, better is the yield. That's the dictum. If the child is intubated, it is always prudent to take the tracheobronchial washing. that is much better yielding. And lastly, since there are certain co-infections, believe me, in our institute in ICH, we have never seen more than 2 virus or more than 2 organisms in the same sample. It's only because of the good sample collection. And having said so, we have seen deadly combination with adenovirus and influenza virus. It's a deadly one to some extent. I think Mirza will definitely agree with it. And is another such deadly combination is maybe there is a pneumococcus pneumonia. Along with it, there is adenovirus. Maybe adenovirus was the pre-existing one. Then there is superadded pneumococcus. In this sort of combination, if we get, then we need to be very, very careful because we may land up in a mess and the prognosis may be explained to the patients. So newer tests in horizon, the spectrum is going to increase, not only this multiplex PCR, but also some reverse hybridization technique, dot blot technique, different techniques are coming out. So in a very few years, I mean, maybe in a 2 to 3 years time, you will be having a tailor-made treatment. That means if it is a bacteria, you will be having the resistance gene as well in your report. So you will be knowing which antibiotic to choose from, even from the PCR report. So that is another aspect that is going to come very soon. Maybe in the next 4 or 5 years time, in India, it will be available. So this is something new one coming in. As of now, I think I have touched all.
Thank you, Shumon. Yes, that was very compact and you covered a lot of questions and information. Thank you very much. Since we're running out of time, I'll just whisk through the next 3 questions. So over to you, Mihir. The child is not improving clinically. What else to look for? You seem to be doing the right stuff, but the child is not, the improvement is not up to the mark. Are we missing something?
Yes, so it is definitely I have already told that it is not the viral pneumonia itself. If there is coexisting pathology like the virus can affect the CNS, it can affect the heart, it can affect the other organs. So if there is coexisting myocarditis, encephalopathy, that should be keep in mind. And the myocarditis itself can lead to worsening the respiratory distress, the circulatory insufficiency, all the things. And if the superadded co-infection and bacterial infection, like the patient like having comorbidities, immunocompromised patient with infant or born low birth weight, NICU graduate. So these are the patients who are more risk of the co-infection with bacterial co-infection. So that we have to keep in mind. And also we have to need the monitoring and escalate the therapy according to that. And this co-infection, coexisting illness, pre-existing illness, all things can aggravate or add to the illness. So that we have to keep in mind and address that.
Yeah, co-infection and comorbidities. Dr. Gauri Shankar, over to you. A viral pneumonia, very innocuous, is it hunky-dory? You just treat and it's a 7-day illness and you've done your bit, or do they come with complications? And if so, what?
Many a times textbooks say it just, even without any treatment, they improve, but you do see them with complication, especially those with adenovirus, probably like Dr. Mihir will agree with me. If it is going to be an adeno, every child who I have seen with adeno, I always follow them up, because I do have 3 children with bronchiolitis obliterans, like now cryptogenic pneumonia, this is what they call. So very difficult to tell them that this is a problem after the viral infection, because we are used to telling the parents, we counsel them, this child will improve in 5 to 7 days. After that, don't worry. And if the child is very small, RSV pneumonia, like 2 months, 3 months, we tell them, yes, child is going to improve in about 6 to 8 weeks time. After that, not much of a problem. They do come back with frequent episodes of wheeze, like whether it is a forerunner for a child to develop an infantile wheeze and then go on to develop asthma. Still, I do not know. So any child who has got a viral pneumonia, I do tell them, if the child develops frequent episodes of cough and cold, please come back. We need to see what is happening. It is not all that rosy.
I would stay with you, Dr. Gauri Shankar. Every story has a chapter in it which deals with prevention. So the preventative aspect, the strategies that are in place in India or globally in preventing pneumonia.
After COVID came, everyone knows how to do sanitization, how to hand wash, how to use sanitizer, how to use a mask. And nowadays we are well aware about the term cohorting. Any child who has got a viral pneumonia or 2 or 3 children with viral pneumonia, you put this patient cohort in a particular place, make them like don't interact with other patients in the ward. So these are simple things to help prevention of spread of infection to others. So COVID has made us learn many things. One of them is trying to isolate them, then hand washing and wearing a proper mask, a good cough etiquette. I think this will help in preventing spread of viral infection, thereby viral pneumonia. Thank you.
Okay, and just to end it on this note, so we are well aware that the two bodies, well, things are in place on a global scale with a combination of interventions to protect, prevent, and treat pneumonia in children. And with that, I would say thank you, and thank you to the experts for taking us through this very lucidly, very crisply, and a vast information condensed in about 45 minutes. So over to you now, Amita, to share some questions that seem to have appeared in the chat box. That is if we do have time. And I would stop screen sharing.
Before we pass on, can I add something? Just one point.
Yes, please, Shuman, do so. Yes.
Yeah, ma'am. Preventing pneumonia on another aspect is prevention of the pollution. That's a national policy making. Yeah. That's beyond our scope. But what we can do, we can reduce using passive smoking in the form, not just in the form of cigarette smoking, but also in the form of incense stick. So that is again another thing that also I think it should be kept in mind.
Yeah, thank you. Amita, are you there?
Yes, yes. I think most of the questions have been answered, but there are some points which have been made, like Dr. Gautam Ghosh has said that rhinovirus is now encapsulated. It may remain for days on the tabletop. And remember, this is the commonest trigger for future asthma. So he has made a point that rhinovirus can be a trigger for future asthma and it may remain on the tabletop. Some points...
Sorry,
yes.
Can I come in?
Yes, yes, sir, please.
Anyone of the learned audience knows what is burning in an incense stick? What is, do anyone know? I know it personally in Katwa. Why the fume comes? Anyone? I have went to Katwa and so it's gobor. It's the cow dung. And the cow dung with smell, and this has been procured. Go and ask any incense factory. The smoke that comes are from just ghunte jaban bole na is cow dung. Is my experience in Katwa.
So if you stop selling incense stick, some of the political parties may be after you.
I am not sorry, but go and search. Cow, you will see in Wikipedia. Cow dung is burning in all incense stick. You just add any perfume.
Sorry, one mosquito coil is equal to 100 cigarettes.
Yes, and that I have learned in Katwa.
Another question by Dr. Ghosh himself was like, can oseltamivir be used orally for stage 2 and more suspected flu? And that was answered by Dr. Gauri Shankar the answer was yes, and you have to start it early. So that is a point to be made, that it has almost no effect if started after the first week of the symptoms. So if you have to start oseltamivir on suspicion, you don't wait for the results. I think if you are very fairly sure, and if the community also has some cases of influenza, you may start oseltamivir.
May I come in for a minute?
Yes, sir,
Please
please.
do. Yes.
Taking
Yes.
you from this question, that if I start oseltamivir later on in the course of disease, the virus will multiply and gets attached to the receptors. That is the rationale. If we start early, we will get a better result. But in clinical practice, in OPD practice, starting oseltamivir on 5th or 6th day, still it gives a very good result if the child is suffering, and the cough improves dramatically after starting oseltamivir, even if I start at 6th day also. So book teaching is perfectly what you are saying, and the optimum result are there if you take it from the first day or second day or third day before actual replication and attachment to the receptors happen. But if you are sure or very sure that it is influenza virus, you can start later on. Some effect may be there.
Can I ask one question to Shumon? Shumon, the
Yes, sir.
PCR is diagnosing nucleic acid, DNA, antigens that can be present in dead organism.
Very true, sir. When the child is suffering, when there is active disease, when at that time we have certain things, because the predominant virus, if it is there, the predominant virus will be growing and the curve will be appearing first. So depending upon if you are getting, again, I will kind of say that never we have seen more than 2 organisms in our hospital if the collection is done by us. Us means our PGTs. Then even if 2 organisms have come, we can say, depending upon the curve, which organism has got better load or more load. This organism, when we say this organism is present, if the load is high, yes, the nucleic acid load is high, that's true. But when the child is suffering and it is matching with the clinical picture, then it corroborates with the result. So without the clinics, without the biochemical parameters, just treating the report is useless. It has to be in a total juncture. Then you need to think of the report.
Okay, another point made by Dr. Shomik Basu was that in adenovirus, the markers can be conjunctivitis, cough, and GI symptoms. And Dr. Gauri Shankar also emphasized that elevated CPK, SGOT, and SGPT are commonly found in adenovirus. So these are some points which have been made. And any other inputs from anybody? I think most of the questions have been almost answered. Dr. Gautam Ghosh had asked in the beginning how to differentiate between RSV and RSV pneumonia and bronchiolitis. So I think the answer was that it would have less chest signs. Bronchiolitis would have less chest signs in the form of bronchi and rales, more distress, and chest X-ray would show more of hyperinflation and less of alveolar exudates. And pneumonia would have more clinical signs of rales and bronchi and more ground glassing on chest X-ray. This was answered by Dr. Rawat. So any more questions or any more inputs?
I think we have answered almost all the questions, and it is almost close to 10.
Yeah, it's been a long day. It's been a very long day.
We are really, really thankful to Dr. Gauri Shankar and Dr. Rawat also, because both of them have spared their time at the back end of the day. We are thankful to Dr. Gautam Ghosh and Mihir Sharkar also, and Shuman Poddar. So final words from the coordinators of the program, Debjani and Amita.
Remember, today is Women's Day.
No, I think this has been not because I've been moderating it, but I think this has been a brilliant session because the overview has covered community peaks, it has covered the OPD desk, it has covered the hospital stay, and it has covered the high-end, high-tech intensive care. So it was truly an A to Z of viral pneumonia. And I would say, if I may say so, very well done to the experts. Thank you very much.
Thank you.
Yes.
Thank you.
Thank you, Dr. Gauri Shankar. We hope to have more of you here to hear more from you in future. Thank you very much. Thank you.
Thank you and good night. Good night.
Good night.
Good night.
Bye bye.